Good afternoon. I'm Alexandra Thomas, a breast medical oncologist at Duke Cancer Institute in North Carolina. Joining me this afternoon is Virginia Kaklamani, professor of medicine at University of Texas Health Science Center, San Antonio. We are here today to talk to you about what we're really excited about at the 2024 ASCO Annual Meeting here in Chicago. There are some exciting new presentations of data in breast cancer. What are the things that you're most excited about?
So I'm excited about looking at the data from postMONARCH. This is a study that's being done looking at a CDK4/6 inhibitor after a CDK4/6 inhibitor. Many of us had incorporated that strategy already based on data from phase 2 trials like MAINTAIN trial. But is this data really panning out in a phase 3 setting? And what is the advantage of adding a CDK4/6 inhibitor after progression on a CDK4/6 inhibitor? So that'll be pretty interesting to look at.
Yeah, I think that will be really interesting. Also, the questions about, do we need to change CDK inhibitor or can we stay on the same CDK inhibitor? It'll certainly generate, regardless of what the data show when Dr. Kalinsky presents it, it'll generate a lot of questions and should alter our practices and hopefully help those patients. I know that when I think about what am I going to do differently on Monday morning, I'm excited about the information that's going to be presented looking at anti-Müllerian hormone or AMH levels on premenopausal patients who are treated in RX Ponder to identify who might benefit from chemotherapy. That abstract, we have the preliminary data from in the abstract, and that really shows that this test that gynecologists typically use, which is a marker of ovarian function reserve, shows who's going to benefit from chemotherapy more than patient-reported menopausal status or other hormone levels.
And I think what's important about that is we've always struggled about what the benefit of chemotherapy is, and is it really the ovarian suppression of what chemotherapy does, or is another cytotoxic effect of chemotherapy that's really helping our premenopausal patients. And AMH, as you mentioned, is such an easy test to do. It's being done by fertility experts. If it's 0, it means that there's no ovarian reserve. If it's more than that, it means that there's some ovarian reserve. So that'll answer, I think, a lot of questions for us.
I feel like I'm seeing a lot of women who are 49, their last menstrual period was 6 months ago. Should I give them chemo? This really feels like that's going to discriminate for those patients, and those difficult questions are going to become easier. You know, I'm also excited about some abstracts that may not be practice changing, but really help us think about where the field is going. There's going to be the ctDNA detection in the monarch-E patients, which we're seeing this blossoming of different assays, and this one may not be exactly the one we're going to use, but I think it'll give us a hint of how we're going to be able to discriminate in the future in the adjuvant space.
And that's where I don't know if you have the same experience, but I have so many patients now coming in and asking for me to perform this assay. And my response has always been no. If you want this done, you're going to have to go somewhere else because I don't know what to do with the results. I don't know how to interpret these results. So analyses like this are going to shed some light as to how to use these results to hopefully change our treatment in the future and really impact our patients.
I couldn't agree more. And we're seeing this already. Some of the other solid tumors are further along in utilizing this tool. So I feel like these presentations here are going to move breast in that direction. You know, similarly, there actually is an abstract that there may not be a lot of discussion about in breast. It wasn't presented in a breast session, but it was presented this morning looking at artificial intelligence to look at the histology of a slide for prognostication. Again, it's not going to change my practice Monday morning, but it gives me a flavor of what we're going to be doing in 2 to 5 years. And then you start to think about what will be the implications globally. Like, can we really, Oncotype's an expensive test. We can't use it globally, but could we really have a histologic picture and harness artificial intelligence to give us some prognostic and hopefully ideally predictive information at a much lower cost and much more available to a broader population.
And I think we'll be able to. We saw a similar presentation at SABCS looking at lobular carcinoma and how AI can predict which cancers are lobular and not based on really mutations in E-cadherin and even more than just mutations, because that test was more accurate in capturing changes of E-cadherin that mutations don't capture. And that's what the future is. So it's extremely exciting.
You know, you're right. I had actually, I remember being struck by that, and I hadn't put those two together. So that is great. great reminder. Thank you. I think we'd be remiss if we didn't talk about the special Sunday morning session, right? DB06. What are your thoughts about that?
So we've already had a press release that shows that the data is not just statistically significant, but clinically meaningful. And this is a trial looking at T-DXd in that first-line cytotoxic therapy in patients with not just HER2-low ER-positive breast cancer, but also HER2 ultra-low. And the press release said also that the results were significant in the ultra-low. So it'll be interesting to see the data. I'm thinking that especially in the HR-positive patient population, if the data is positive, we won't be thinking of T-DXd as HER2-low or ultra-low. We'll be thinking of it for every single HR-positive breast cancer patient. And then moving it in that first-line setting is going to help because now we have to give one line of chemotherapy before we can give an ADC.
You know, that is a really practical angle on that we don't have to spend it like they were first HER2 0 and then HER2 1, and which one is it, that we really have that available for the population. You know, from a scientific perspective, if there's really a biomarker, the HER2 is expressed in all cells, but it's over amplified in HER2, you know, what we've traditionally considered positive. I'm curious about the scientific perspective about what does a biomarker mean here? And do we need to be thinking about biomarkers somewhat differently as we move into this ADC era?
And I think the key is going to be how are we measuring this biomarker? Is immunohistochemistry the right tool? And I don't think it is. There's ways to measure HER2 that has to do with RNA expression that might be able to predict, because what I think is going to be shown at some point is that the benefit of T-DXd is going to change depending on expression levels of HER2. But how do you measure these expression levels? And with IHC, it doesn't seem to make a difference. So maybe more accurate tests can tell us that, because now we have a lot of ADCs, right? Yeah. And we're going to come to a point where we have to decide between 3 or 4 ADCs, and how do we make that decision? And I think it will have to do with that biomarker for each ADC.
Another abstract that I'm really intrigued about also relates to what was presented at San Antonio, this BRAVE trial, the phase 3 study which looked at avelumab, again in the adjuvant space. And we saw at San Antonio with Impassion 131 that giving checkpoint blockade, or the Alexandra study, finally a trial named after me, and it was negative, but that giving checkpoint blockade when the tumor was gone really didn't help. I'm intrigued to know what this will show, and if it were positive, would it be a different checkpoint blockade therapy? If it's negative, does it really add to the data?
With the thought being that to have immunotherapy work, you need to have the tumor to generate that immune response. And if you don't have the tumor because you've excised it, how is this immune response going to be generated? It'll be interesting to see this data because it'll be practice changing in one way or the other.
Yeah. Another trial that I'm particularly intrigued about is this, the Patricia cohort from the SALTI 1303 study. I'm highlighting this one because it offers palbociclib, trastuzumab, and endocrine therapy to HER2-positive metastatic patients with HER2-positive metastatic disease that's luminal. These are a group of patients that we've historically given HER2-directed therapy with chemotherapy, and you just feel like, why am I giving them chemo?
Too much.
And we've had smaller groups of data that have suggested we can do this, but finally it feels like it's going to be larger data. It'll be attractive to understand more about non-chemotherapy options for these patients.
And I feel that the evolution of CDK4/6 inhibitors is going to be in that HER2 space. We've already seen the MONARCH HER trial with some activity of abemaciclib.
Exactly.
So trials like this where there's a combination, especially as you mentioned, and I think that's the key to this trial, in that specific subset that's still luminal. It's not the HER2 enriched. It's not the basal that some of these HER2 positive cancers could be. Will shed some light.
You know, that's such a great point, Virginia. I wonder if this is a space where we're going to start using the HER2-DX test, if that's going to become available for us.
I think you're right. I think, this test is showing good prognostic capability, some predictive capability as well. So it might help us differentiate on how to treat these patients with HER2-positive breast cancer the right way.
Yeah, I've increasingly in the clinic felt like not all HER2-positive breast cancer is the same. And we really need some better tools to help us identify how to treat these patients differently. Anything else that you're really excited about here at the meeting?
So there was an abstract looking at ER positivity in that low ER category, 1 to 10, and interestingly suggesting that there is a benefit of endocrine therapy in this patient population that has a low ER positivity. Now, standard of care is to give them endocrine therapy, but we've all kind of thought of how much benefit are we really getting. And the abstract has several limitations. I think the data needs to be looked at in a more granular fashion, but at the same time reassures us that we are doing the right thing by giving endocrine therapy, and further data might help distinguish this, again, ER ultra low, getting maybe to 1, 2, 3 percentage points versus the 8, 9, 10 percentage points.
And highlights that this is a really important question that we struggle with in the clinic every day. I did like that in that presentation they showed that there appeared to be, again, numbers start to get small. This is a retrospective data set. But for patients who had achieved a PCR, the benefit appeared to be lower. Mm-hmm. And that's important piece of information in the clinic too. It's been so great to see you today. Thanks for joining me. This is Alexandra Thomas speaking from the 2024 ASCO Annual Meeting in Chicago. Thanks for joining us this afternoon.